a good FB Live session. Today, we have with us Dr. Anila Chandy, who is a consultant physician at Motherhood Hospital. Today, she's going to talk about the gestational diabetes, that is the sugars or the diabetes which occurs during the pregnancy period. Welcome, Doctor. Thank you. Doctor, what do you think is the difference between the prime diabetes and the gestational diabetes?
Right. The difference is mostly in the diagnosis and when it occurs. Gestational diabetes is diabetes that is glucose intolerance that is detected for the very first time in pregnancy. Usually it's around 24 to 28 weeks, which is when we advise pregnant women to do an oral glucose tolerance test in order to diagnose it. With frank diabetes, the diagnosis is based on a fasting blood sugar of 126 milligrams percent or more, or a random blood sugar of 200 milligrams percent or more, along with symptoms of diabetes, which include increased thirst, increased urination, weight loss, increased hunger. Now, if these symptoms occur along with a random blood sugar of 200 or more, that's over diabetes. It could also be a reading of 200 milligrams or more on a 2-hour postprandial reading of 75 grams glucose load. Okay. And also, if the HbA1c is more than 6.5, so there are any of these 4 criteria, if they're positive, that's over diabetes. The diagnostic criteria are slightly different in gestational diabetes. In over diabetes, I said more than 126, more than or equal to 126. But in gestational diabetes, the cutoff is 92. So, so the fasting of 92 or more, and an oral glucose tolerance test reading at 1 hour if it's more than 180, at 2 hours if it's more than 153. Any of these readings, if they are abnormal, they consider gestational diabetes. And once you're diagnosed, you don't really have to do a GTT again after doing your diet control. You can just check your blood sugars and see if they're monitored.
So what do you think is the risk of having high sugars at the time of conception? Your mother gets conceived, they're having high sugars.
Right. At the time of conception, before somebody plans pregnancy, it's always advisable to check blood sugars if you're planning pregnancy. Reason being, pre-gestational diabetes, if it's uncontrolled, that is, before pregnancy, if the patient is diabetic and the blood sugars are high and the mother doesn't know it, it can actually cause a lot of problems in the baby. It can cause miscarriages, it can cause cardiac and neurological abnormalities. Therefore, it's very high risk to the baby. If the blood sugars are high toward the end of pregnancy, the baby ends up big. Now, what is the harm of having a big baby? It's good to have a big baby, but the problem is there are these hormones called insulin-like growth factor, which is increased. That increases every organ tissue in the body, including the pancreas. So when the baby comes out, pancreas is big, it produces a lot of insulin. The baby has a chance of going into hypoglycemia. Apart from that, the baby has a difficult time during the delivery, and chances of a cesarean section are also higher. Gestational diabetes per se is a risk factor for urinary tract infection and preterm rupture of membranes and preeclampsia also for the pregnant woman. So it's always better to detect it early and to treat it, because then you're saving both, right?
So what do you think, what are the symptoms a mother can expect, or what will she expecting during her gestational diabetes? Say a mother's been diagnosed with it. So what are the symptoms?
Most of the time, it doesn't have symptoms except for insulin resistant symptoms, which could be blackening, a velvety blackening around the neck or on the armpits or even skin tags. Those are signs of insulin resistance, usually in women who are a little more obese than they are allowed to be. And the symptoms of over diabetes are exactly the same as pregnancy symptoms. So somebody wouldn't really be able to tell if the patient has diabetes unless somebody has tested for it by a glucose tolerance test. So this glucose tolerance test that we do is usually done at 24 to 28 weeks. The patient first comes in fasting, after 12 hours of fasting, checks her blood sugar, takes 75 grams of glucose. Either you can eat it up or you can drink it in water. 1 hour later, check the blood sugar, and 2 hours later, check the blood sugar. That's how we diagnose it.
Right. So can you tell us, suppose the mother's been diagnosed with gestational diabetes? What do you think about the diet and exercise which they should follow during the pregnancy?
Right. Now, diet is the crucial thing in pregnancy when you have gestational diabetes, because many gestational diabetes can just be controlled by diet and exercise. Right? It is essentially, why does gestational diabetes occur? It's the placenta that is actually producing a lot recorded this human placental lactogen that actually is a diabetogenic hormone. Now, what do I mean by that? It increases blood sugar, basically, essentially for the baby to grow. But it's a little out of proportion because of the insulin resistance and the hormones. The trigger factors are different, and therefore this person develops over diabetes, gestational diabetes. So it's a state of insulin resistance per se. Now, diet would actually prevent the blood sugar from fluctuating too much and bring it down under control in many people. So, what we would advise is, first of all, cut off all the simple sugars, like all kinds of sugary drinks. People take fruit juices and packet of juices and they think it doesn't have sugar. No, but just read the amount of sugar that's been added to it. Better to avoid all kinds of sugar, plain sugars. And take complex carbohydrates, they're very good. That is your brown rice, whole wheat grains. That's definitely preferred to white rice and to things like idlis are also supposed to be good. What I usually advise my patients is you check your blood sugars after each meal. That's 1 hour after breakfast, 1 hour after lunch, 1 hour after dinner. That's how we monitor it. Not 2 hours after, just like in over diabetes. Here it's 1 hour later. We want it to be ideally 130 or less. If it's anything more than 150, and the diet is not enough, we have to put them on medication. So you can see the pattern. If you make a chart, you can see, okay, this is what I've eaten, and this is my blood sugar after that. So you can your own intake, your own diet, and that's how we do it. Now, in somebody taking insulin, it's necessary to take 3 main meals and 2 small snacks or 3 small snacks in between, so blood sugar doesn't fluctuate too much. You don't go into hypoglycemia, which is very dangerous for the baby.
So, what are the exercises? How frequent?
Exercise, 30 minutes of exercise, unless contraindicated, like in things when placenta has low lying, conditions when placenta has low lying. We would definitely advise some exercise, brisk walking 30 to 40 minutes a day. It's very good for glycemic control.
We were talking about the medications which can be given. So, what are the medications that can be taken orally during the gestation?
Right. First of all, the drug choice in gestational diabetes is insulin, and oral medication can be given. There have been studies that are showing that there is almost equal outcome. If somebody takes insulin and somebody takes metformin, it's almost the same outcome for the mother and the baby. However, metformin does cross the placenta. You should remember that, and insulin does not. That's why insulin is still the drug of choice in pregnancy. Now, metformin after 34 weeks of gestation, taken by the mother, it can cause hypoglycemia, increased hypoglycemia in the baby. However, the risk is not that much, so it's being given more and more frequently nowadays, especially when insulin resistance is high and when the patient is on very high doses of insulin. We start metformin, they're fully control. And if somebody is already on metformin for reasons like PCOD right from the start, we definitely do not want you to take it off. Increased risk of miscarriage. Take it on right to the end. Insulin, we prefer short-acting insulin. Now, there are different people follow their own techniques, and they found brilliant results. I too have found brilliant results with the way I give the insulin. I usually prefer short-acting insulin, Act Rapid, because it acts for about 4 to 6 hours. That's just about till when you take your next dose of insulin. So, if I check fasting blood sugar at 7 in the morning, I take my insulin, and about 7:30, 7:40, I can take my meal. 1 hour after that, I check the post-breakfast reading, and then I take a pre-meal insulin, and check the sugar 1 hour after lunch, and the same thing with dinner. Now, you have to realize that fasting blood sugar will not be altered by short-acting insulin that's given at night. Reason being, short-acting acts only for 4 to 6 hours. You take it at 8 o'clock in the night with a short-acting Act Rapid, your blood sugar in the morning is not going to be affected by that. You need an insulin, which is intermediate-acting insulin, Insulatard, at night if your fasting blood sugars are high. Usually, if the fasting blood sugar is more than 100, you have to have insulin at night. Now, it's very easy for you to control your own diabetes if you know how to adjust it. It's almost about 1 unit brings down about 10 milligrams. So you can calculate it, and then you can see based on the chart that you name. So supposing I don't usually alter the drug doses based on that day's reading. I usually do it the next day, which is very good because you see the pattern on one particular day.
I'm using this for my
And
clinic.
you see, supposing the fasting blood sugar is 200. That night, I would probably say 6 to 8 minutes. The next day morning, I checked the blood sugar. The fasting blood sugar would be dependent on the dose that I had
I'm making
this
my
time,
website,
right?
Mummy, one
So
new
if it's
name
8 and fasting comes up to
software
100, no problem.
techniques.
If we can increase by 1 or 2 units more, bring it around 90, which is perfect. We don't want it less than 80. Now, the post-breakfast reading, if it goes up to around 200, you need a short-acting insulin with breakfast. That short-acting insulin, say it is 6 units. You see, the next day, it's still not getting controlled. It's still 180. The next day, you will increase the dose by a bit, 2 to 4 units of insulin. So that way, I have seen mostly that post-breakfast readings that go very high in patients. Lunch, many people don't require any insulin with lunch, and some people require lower dose of insulin with dinner. That's the usual trend that I've seen in many patients. So I wouldn't usually prefer to give a combination insulin twice a day because some people have very erratic blood sugars with that. I prefer to do it this way. It's very accurate control, very small amounts of insulin with great results. Now, there are patients who have very erratic blood sugar readings. And you really cannot determine the amount of insulin that is necessary. So, in those patients, insulin pumps are usually preferred. Insulin pumps are essentially little devices with a subcutaneous needle, and it's sitting inside your skin of the tummy. And it just delivers continuous doses of very small acting insulin. So, whenever it maintains a basal level of insulin blood, just like a normal person. And if you take a meal, all you have to do is up the dose just for that meal that you eat. So it's brilliant the way it's been controlling sugar. The patients are very difficult to control the diet. So there's lots of things available nowadays for controlling gestational diabetes.
I think the many people have got an idea how to monitor the blood sugar. How can we adjust the according to insulin according to the situation?
Yes, I hope so.
So, doctor, do you think a mother gets really paranoid when she hears the term gestation because everybody browses through it and they go through it and like, okay, gestation. So, it's a real thing to get scared about?
It's nothing to get scared about. However, I must say that 40 to 50% of gestational diabetics end up being frank diabetics later on in their lives, maybe about 3 to 5 years later. So what I would recommend, though, your blood sugars drop to bang normal once the placenta is out, patients' blood sugars are normal. Even patients I've seen, they are on 100 units of insulin, but as soon as the baby comes up, placenta is out, the sugars are normal. You don't need any insulin. But it's always advisable for the mother, for her sake, to continue the same diet restrictions and exercise. It's very good to prevent it. It's shown that diet and exercise would reduce the risk of developing diabetes by at least 30% reduction. And of course, check your GTT once in a year at least. That if you're developing diabetes, you can take it early. Right. So there's no real reason to get upset about gestational diabetes because there are wonderful drugs to control it. Do your bit for those few months left of your pregnancy. Enjoy your pregnancy. Nothing to get worried about. But the only main concern would be to get. You should not be getting a higher dose than what you need. Blood sugar should never become hypoglycemic because that is much more dangerous to the baby than to have high blood sugar reading. So if you have any doubts, please contact your.
Actually, we have some questions at the last. So, Ms. Anita Gopal had asked us whether gestational diabetes will affect the baby later in, the baby's life later on in the baby.
If the blood sugars are well under control and the pancreas is normal size, and there is no reason why the baby should develop problems later in life. However, if the baby is large, if the mother's blood sugars are way out of control, it could. We don't know, but studies have not been done on the babies, so we don't really know. We don't even know about people who are taking drugs that cross the placenta, like glyburide and metformin. We don't know what the outcome is later on because it alters the phosphofructokinase gene, and that gene is necessary for gluconeogenesis. Once you reduce the dose, you alter the mechanics of that. We don't know if it's harmful, but so far the studies that have been done in babies and mothers have proved that it's not so harmful. So people are taking it happily.
So this one.